Thank you, Lord Chairman, and good morning, and thank you very much to each of our panel members for giving us your time today. I've got two lines of inquiry that I'd like to explore, and for each I'd like to invite each of our panel members to comment if they wish to do so. The first of these is around the theme of discrimination in healthcare decision-making. The COVID-19 pandemic exposed health inequalities and failures in decision-making, most notably the inappropriate application of DNR orders on patients, including disabled people and people with learning disabilities. And there have been experiences shared throughout the passage of this bill of experiences of discrimination in healthcare. And so my question is, in light of the widespread experiences of discrimination for disabled and learning disabled people, do you have concerns about the preliminary discussion being a process in which a doctor can raise assisted dying with patients? I'm happy to hear from any panel member if you wish. Thank you.
Yes, I'm personally very worried about that. Within separate legislation, the Down Syndrome Act, we've pushed since inception for there to be Down syndrome specific training for health and education professionals. That has been resisted now for 3 years and is actually unlikely to come into force. People with Down syndrome have a very complex and unique speech and communication profile. They're highly suggestible. Even someone wearing a uniform could suggest that position of authority to them is something that they should show acquiescence to. You know, the acquiescence bias risk from people with Down syndrome is extraordinary. So they could have a seeded view around what they think that person wants to hear and talk about without fully understanding the position. There is obviously a protection under the Mental Capacity Act, but the Mental Capacity Act in itself lists the qualifying example as having a severe learning disability. 23 definitions within the NHS that I found in relation to Down syndrome about learning disability described it in various different ways, but essentially as either having a learning disability or mild to moderate, which then brings in every person with Down syndrome to the scope of this act. If the physician does not know how to communicate with them, does not understand that leading questions can provide answers that the patient thinks they want to hear but may not actually represent their views, is extremely worrying.
Thank you. Disabled people experience discrimination in every walk of life, whether that's, at the moment, discussions around benefit cuts, about inclusion in transport, education, employment, access to work. And healthcare, I think, is one of those areas where there's a lot of assumptions made about ability and disability. So when we talk about a disabled person, it's quite a wide, we're not one homogenous group of people, and everyone has quite a different range of impairments. Certainly around COVID, a large number of disabled people got in touch with me to tell me they'd had DNR orders put on them without any discussion with them at all. And that made, I think, a number of disabled people very nervous about accessing the care system. And we've seen that in Canada and Australia, that people are really nervous about accessing healthcare because they think, certainly in Australia, there'll be a discussion around euthanasia. From my own experience, when my father was ill and he'd had to have his foot amputated, a doctor took me to one side and said, you might want to have a chat with your dad about continuing on healthcare, because as a wheelchair user, he will not have any quality of life. And that made me and my family extremely nervous about him remaining in that hospital. I think we then very easily slips into coercion. Coercion is very variable. If you already think that you're better off dead, or you're having problems with health and social care, you can't get the care you need, you're living in poor housing, it will be very easy for disabled people to have it suggested to them that this is a route to choose. And we are told that, it's not for disabled people, but there are a range of conditions that would very easily fit into a terminal diagnosis, like cystic fibrosis, or if somebody like me got a pressure sore and it didn't heal, I would very easily fit into a 6-month diagnosis. I've had 3 friends who've died from pressure sores. So it absolutely would cover disabled people, and we are very poor at determining the difference between sick and disabled, or illness and disabled. A lot of our legislation will talk about sick and disabled people, and that's why I think it's absolutely possible that suggestions will be made to disabled people that, you know, think of the family, think of your carer, think of the people around you. It will be suggested that this is a good route for disabled people to think about.
Thank you. Any of the other two wish to comment?
Yeah, I'm very concerned about discrimination against disabled people in healthcare. That's why I'm one of the co-chairs of the Lancet Commission on Disability Health, which is all about that. Certainly, I think that there is risk of discrimination. I think DNA CPR is not relevant to this conversation because this is about assisted dying, which is not DNA CPR. Very different. I think it would be discriminatory to say that people could not have this if they're disabled or if they've got learning difficulties or whatever. I think every healthcare professional now has training in autism and learning disability obligatory by law. That may not specifically cover Down syndrome as a specific separate diagnosis, but there are 5,000 or so, whatever it is, single gene disorders. There are many developmental disorders, many chromosomal disorders. You can't have training on every single one of them. You can have general training about the fact that if you seek to influence somebody with learning difficulties, you might be able to do so. But that surely covers a lot of people with learning difficulties. It's not about the specific diagnosis, it's about the ways that a health professional should be careful not to unduly pressurise. And I think or that people are more biddable or whatever. I think within the bill as it stands, there is safeguards. There are more safeguards here, and there's been more amendments to the existing bill, which I think would remove that danger. End.
Thank you.
Thank you. Just very briefly, a couple of points to make. Yes, this is obviously something to be concerned about. I think there have been good attempts to improve the bill already to try and deal with some of these issues. The introduction of the independent advocate is a possibility. It's also going to be something that's very important to build into any codes of practice made under the bill. But I think I would just say that this is a known problem. We've already had mention of the DNA CPR in the context of COVID in particular, and that's something that the EHRC looked into during the pandemic. I think it's also worth saying that however good the training is, this can be a difficult thing to get right in practice. So there are kind of quite entrenched health inequalities that are difficult to deal with. Just to give one statistic, the July to August 2025 ONS data from the Health Insights survey showed that 41% of people with disabilities are on an NHS waiting list compared to just 10% of those who aren't. So just at that kind of very basic level, you get big inequalities. And that can feed through to the way that any kind of particular discussion, particularly the preliminary discussion in this situation, could be affected on quite a sort of wide level, which is again why we've made the point about building in concern about wider coercion or pressure, not just individual circumstance coercion or pressure.
Lord Patel.
Thank you very much. Thank you, Lord Chairman. Thank you, all of you, for